Opening statement.
Thank you very much, Candice. Good morning to Dr. Hines. Good morning to Dr. St. Bernard. Good morning, ladies and gentlemen of the media, and to all persons listening or viewing on the different platforms. So today is Monday, 14th September, and we are here to report to you once again. My little 5-10 minutes this morning is going to be spent trying to inform the public about how far we have come successfully in this whole issue of COVID as we try to adapt to the new normal, but also how far we have to go because the battle is not won, the journey does not have an end. And I would like to use two examples over the past few days to demonstrate how far we have come, how we can return to some degree of normalcy under the rubric of the new normal, but to also use an example of irresponsibility to show how far we still have to go. How far have we come? I think the issue of the CPL, which was successfully concluded last week Thursday, demonstrates to the world how far we have come. That we could have hosted an international tournament in one location. We built what is commonly called now a biosecure bubble, and international sport can in fact go on without any problems. I want to sincerely congratulate every single stakeholder who worked together to bring off CPL. And that is what we mean by adapting to the new normal. Yes, you didn't have crowds, but the tournament was able to go on. Trinidad and Tobago was the focus of the cricketing world for 3.5 weeks. We showed how we could adapt to the virus and live with the virus without crowds, but the tournament happened. We had 3.5 weeks of national pride on display throughout the Caribbean. And we demonstrated that yes, we can in fact adapt to the new normal. So we have come a long way in understanding how to live with COVID. But on the other end of the scale, how far do we have to go? Because there are still some persons who worship on the altar of denial. And it is these individuals who will capsize the entire thing. And I refer specifically to a video which that individual posted. I was in two minds as to whether to show the video. I have decided not to show the video. Everyone has seen it. But I think what is more instructive is her narrative. And her narrative goes like this. We're not risking anybody's lives because it's just us, family here. But let me tell that person who worships on the altar of denial, and I wanted to use some other words this morning, but I will not. You are risking your life. You are risking other people's lives. You are. Because she goes on to say, we know each other's whereabouts. You may know that person's whereabouts on the beach. But would you put your head on a block and swear on a holy book you knew where that person was for the past 2 weeks? That you knew for a fact that where your guests worked, the workforce did not have COVID. You knew and swear on a holy book that you knew where that person was for every second of every day of every hour for the previous 2 weeks. You would have heard Dr. Hines said that when we are doing contact tracing, people are not always straightforward with us. So we know who we are around. Not that I need to explain this to anyone. Well, let me tell that person something you need to explain to my healthcare workers. Because when you get ill, you are coming to my hospital, and I'm using the word my for emphasis. You are coming to my hospital. Are you going to build an ICU in your house? I'm talking directly to that young lady and all of those who worship on the altar of denial. When you are ill, whose hospitals are you going to? Whose healthcare workers are going to take care of you? Your own? You have oxygen in your house? You have a heart monitor in your house? You have a ventilator in your house? You have IV set up in your house? No. You are going to come to my hospital. That is what this type of denial is doing. And to emphasize the point, we are now 6 months into a global pandemic. And the undeniable fact is that yesterday, September the 13th, the world recorded yesterday its highest one-day total of coronavirus cases. 307,930. This pandemic is not going anywhere. It is in our beaches, in our homes. And we have demonstrated here conclusively that it is young persons driving our second wave. Again, those young persons who worship on the altar of denial, and I promised myself I wouldn't say it, but I am going to say it now, and who also worship on the altar of stupidity. That will crash the system. Could you imagine if countries around the world did not employ all these public health measures, what that figure of 307,930 would have been like? Healthcare systems around the world that have crashed and those who have not crashed like ours would have crashed. Instead of talking about 53 deaths, is it this morning, Candice?
54.
54. It may have been 540. It may have been 5,400.
54.
Ladies and gentlemen, if today we don't put down a marker for our young people especially to get serious, I don't know when else we will do it. Israel has gone into their second major lockdown. Their second major lockdown. Lockdowns are not the solution to this crisis. Because when you lock down, you don't kill the virus. What you kill is the economy. That's what you kill. And we are part of a responsible government, given a responsible result, trying to keep as many aspects of the economy open. I am imploring the young persons of Trinidad and Tobago, as characterized by the most reckless post by that young lady. You represent a clear and present threat to my livelihood, to the livelihoods of every single worker in Trinidad and Tobago. And I pull no punches this morning as I close, that you characterize the worst of young people in Trinidad and Tobago. Do not be a cheerleader for that. We are all in this together. So the CPL represented the best in us, and it shows how we could adapt to the virus. It's not all bad news. The CPL represents how far we have come, in a good sense. But all that was undone by that representative of that small part of the population. And it's a small part, many people are responsible. But it just takes one person to infect 10, 10 to infect 100, 100 to infect 1,000. So I am appealing again to young persons. Yes, this coronavirus epidemic has placed a significant social burden on you. But we have to respond in the most responsible way. So that small percentage of young persons who are not getting the message, I ask you to consider your actions, reconsider how we are responding, so like CPL, we could continue to save lives and have a livelihood. Ms. Alcantara, those are my few words this morning, and I thank you for the opportunity.
Thank you very much, Minister Dayal Singh. And now, Dr. Hines will present the clinical and the epidemiological update.
Thank you, Ms. Alcantara. Good morning to the Minister of Health, to my colleague, Dr. St. Bernard, members of the media, members of the viewing and listening public. The update for this morning, Monday, September 14th, is as follows. To date, we have processed 27,006 samples which have been submitted to the Caribbean Public Health Agency, UE, and the other local sites for testing for COVID-19. Of those, 23,963 would constitute unique tests completed. The number of repeated tests stands at 3,043, and the number of samples having tested positive stands at 3,091. There are currently 2,250 cases deemed as active, and there are to date 54 deaths, one more person having passed on, and again we extend our condolences to the members of the family. 787 persons have been discharged, and between the last update and now, you will note that there have been 49 additional individuals tested positive for COVID-19, and this total shows samples that were taken across the period September 3rd to September 12th. Again, not representative of a single 24-hour period. The other updates with regard to the clinical side of things, the clinical institutions, as follows. We currently have 102 individuals in hospitals spread across the Couva, Cora, and Arima facilities in the following way. At the Couva facility, we have 70 individuals, 3 of whom are in ICU and 5 of whom are in HDU. At Cora, we have 27 individuals, and at Arima, we have 5 individuals in ICU. There are 128 individuals in step-down or transition facilities. There are no persons at the Brooklyn, Belandro, or Tacarigua facilities at this point in time. UE Debe has 7, UE Canada Hall has 50, UE Freedom Hall has 71, and the Napa facility has none. Overall, the capacity of the clinical system is occupied around 38 to 39%, and in the quarantine facilities utilized for repatriation, the capacity is around 55%. That brings me to the end of the clinical side of the update. We do have some epidemiological data and slides to share, so I'd like those to be put up at this point in time, and we continue straight into that. One of the things we want to point out is the demographic distribution of both the cases and the deaths from COVID-19 as the data stands at this point in time. Although the slides are quite small, the information is generally shared subsequently. And what we do want to point out is that the persons in that 25 to 49 age group occupy about 56% of the total number of COVID-19 positives. The breakdown for male and females is actually on this slide, and we can disseminate that at a separate point in time. Of note, the fatalities, if you look at the the right side of your screen, the fatalities show a slightly different pattern, as we've been explaining, and that pattern shows a predominance of males and also individuals in the above 60 age group being the majority. But fatalities are not limited to individuals in that age group. As the graphic shows, there have been fatalities as far down as the 35 to 39 age group, and those are in the minority, but they emphasize the importance of everyone, regardless of age, taking good care to take note of symptoms, to access care early, especially if they're aware of having any underlying conditions. But even if you're not aware, the emphasis today is on ensuring that the entire population takes respiratory symptoms in a more serious manner, because no one is immune to the virus and no one is assured that they will not have an adverse outcome. So the age groups that we're demonstrating there reinforce what we've been saying on a repeated basis, usually in the older age groups, but there have been some exceptions. We're emphasizing the exceptions today as opposed to the older age group, so that no one feels that they're exempt from concern. The next slide is the epidemiologic curve. And what we do see here is three separate colors. The first is that last period of July, from July 20th to July 31st, where there were a few cases at the start of what we call our second phase. And the purple represents the month of August, day by day, where we are seeing that increase that was noted across the month of August, with a few peaks or a few spikes, usually on Mondays, because individuals go to test on Mondays. So what we did find is that there may be troughs during the weekend and increased numbers of persons coming for testing on a Monday or a Tuesday. So those days had the higher numbers of individuals seeking care. And as we progress towards September, we are seeing slightly smaller numbers, and we are hoping that this trend indicates that the measures that have been implemented are beginning to take some sort of effect. It does take a few weeks for the effect of public health measures to start to be seen, and we're hoping that this is actually the start of that trend. We will continue to monitor and we'll continue to update as the information becomes available to us. The next slide shows something that we have not referenced before, but we have been monitoring continuously, and this is the actual month-to-month mortality from pneumonia-related causes. What we've done is, in conjunction with the Ministry of Legal Affairs and the Office of the Registrar General, we have been looking at the patterns of mortality, both all cause, meaning everyone, whatever they died from, and specifically anything that referenced pneumonia as the cause of death. And the gray bars, the thick gray bars, show our month-to-month numbers of deaths from the pneumonia-related causes. The red dotted line that you see going across the graph represents the average number of deaths for the previous 3 years for each of the months in question. So the red line shows on average that the deaths for this year have not surpassed that average number of fatalities from pneumonia. What we do is we continue to monitor for what we call excess mortality, more deaths than we expect, more deaths than is usual. And while we do see that there have been increases between May and August, those increases have not yet surpassed the average, but we continue to monitor, because this is another good metric for when there are unreported or undetected issues that the health system needs to address. And to date, we do take some comfort in this data, as it recognizes that we do not have an uncontrolled and undocumented issue, and that the intervention of the health system may be in fact managing to prevent excess mortality at this point in time. Continuing to hold fast to the public health measures and to improve our compliance with those measures will also improve the mortality in this particular domain, outside of the people that actually come forward for testing. This is just across the board. The next slides show the geographic distribution of the cases. Again, just reminding us where we were with respect to phase 1 and phase 2. Phase 1 being the red dots that we now have difficulty to see because they are overshadowed by the greater respiratory illness activity in phase 2, and the purple dots being the representation of the quarantined individuals. Moving to the next slide. What we just see is phase 2 with the quarantine/repatriation group, and when we take that away, moving to the next slide. When we move to the next slide, we see just the blue circles, which represent only the local phase 2 cases, and again we see distribution across the population centers, growing numbers in areas where we had previously not been seeing a large number of cases, so growing areas along the eastern side of the country where we had seen clear space before. So again, where there are people, there is virus. There is no particular location that is immune or virus free, and we do need to apply the measures and the recommendations across the board in order to slow the spread of the virus to the greatest extent that we can. I turn you back over to Ms. Alcantara.
Thank you very much, Dr. Hines, for those insights. And now some words from Dr. St. Bernard about protecting your home from COVID-19 and measures that you can take when you have COVID-19 positive persons in the household.
Hello and good morning, Minister. Good morning, Dr. Hines. Good morning to the media. Good morning to the viewing and listening public. And of course, good morning to Ms. Alcantara. So as she has said, we will be looking at a couple of things today, including how to protect your home. I will also be providing an update on clinical monitoring as well as pitfalls to avoid when self-monitoring at home. So in order for us to monitor for worsening symptoms regularly, COVID-19 patients that are at home, as well as their caregivers, need to know the signs and symptoms of complications, and they also need to know how to recognize a deterioration in your health status that would require medical attention. These need to be monitored regularly and ideally twice per day. The worsening symptoms that we look at, which I would have mentioned before, and I will mention again now, increasing shortness of breath, headaches, dizziness, being in and out of consciousness, uncoordinated movements, or even drowsiness. These are some signs of worsening symptoms. Some other signs include increasing fatigue, you are just tired and you cannot shake it, chills, persistent fever, as well as chest pain or discomfort. In children, parents and caregivers of children who have COVID-19 would also need to monitor them for any signs and symptoms of clinical deterioration which may require urgent re-evaluation. And that would include in children difficulty breathing. Sometimes they take fast or shallow breaths. Their lips may turn blue or their face. They may describe chest pain or pressure. They may be newly confused. They may be unable to wake up. So you've put them down for a nap and you are not getting them to wake up. And they are not keeping down any liquids, or they don't want to even drink. So coming back to the communication with the physicians and how we are actually monitoring twice daily while you are at home with COVID-19, physicians have established a means of communicating with the caregivers of persons with COVID-19 or with the COVID-19 persons themselves for the duration of the isolation period, and this has been via telephone calls. So patients are called twice a day by the physicians, and they are asked to give an update on how they are feeling, what symptoms they may be having, and of course if they have a pulse oximeter, what are the readings. I'd just like to give some examples of symptoms that have been reported to us by the COVID-19 persons at home, because every day they submit reports to the county medical officers of health, the physicians who call. And some examples would include things like just an occasional cough, a slight wheeze, no shortness of breath, feeling very well. Some complain of body pain, some neck pain, back pain, a minor sore throat, fever. Some people say they're just a little bit tired, or they're only short of breath when they exert themselves. And some would complain of cramps in their legs and so on. So it's all kinds of symptoms persons would communicate with the physicians when they are called. I want to speak about some concerns that we're having, right, from our observations. So patients are sometimes downplaying their symptoms or signs of worsening in order to avoid possible admission to Cora or Couva Hospital. And that is a dangerous practice, and it really should not continue. We are asking you, we are begging you, please contact the physician who's been in contact with you twice daily, or you are free to call 811, where the GMRTT personnel will visit your home to make an assessment. Sometimes they will visit, they will make an assessment, and when they communicate with us, we would say, okay, we can continue to observe at home. Sometimes when they visit and they make the assessment, after conversation with the specialist medical officer at the hospital, we would make a determination that you need to be admitted. You are not an inconvenience. We all want good outcomes, and we want persons who are being managed at home to recover fully and return to normal life as soon as possible. What about if you're accustomed to having symptoms? That's another observation that we have made. Even if you are accustomed to having shortness of breath, for example, because you're an asthmatic, we are asking you to still call. This shortness of breath may be due to COVID and not your usual asthma symptoms acting up. So I beg you, report your symptoms to the physician calling you twice per day. What about if you develop worsening symptoms? GMRTT is always available via 811. The ambulance personnel will liaise with us. We will liaise with the doctors at the hospital, and we will make a determination as to what is best for you. How long will I have to stay in hospital? That's a concern that people have. If upon assessment by the GMRTT personnel, we think it is necessary for you to be admitted to hospital, you will receive the care that you need until it is safe for you to return home, back to your care at home, where we can continue where we have left off, which is calling you twice daily. So some of our patients have in fact gone into hospital for a few days. They have received oxygen therapy and other medical support, and then they have been discharged home, where we have continued our monitoring via the telemedicine team. But sudden deterioration can still happen in spite of all that we are doing. Despite everyone's best efforts, sudden deterioration of someone's condition can still occur, and of course time is of the essence in these circumstances. Ensure that you are not alone, and so someone else is available to call on your behalf. GMRTT will respond. I would like to ask at this point, please, that you ensure a proper address is on file so that the ambulance is not spending time driving around trying to find you. Give landmarks to your physician calling so we would all know how to find you, and quickly. So in terms of protecting yourselves at home, this is a statement I want to say. Not because you are at home, it means, okay? So not because you're at home, you have the luxury now of being managed at home with COVID-19. Not because you're at home, it means you don't wear your mask. I have personally seen persons COVID positive that were not wearing their masks when the pulse oximeters were being delivered to their homes. A medical mask should be worn by the patient, worn as much as possible, and changed daily and whenever wet or dirty from secretions. You should practice good respiratory hygiene, that is, cough or sneeze into your bent elbow or tissue, and then immediately dispose of the tissue, followed by the hand hygiene. Not because you are at home, it means you do not use soap and water to cleanse your face coverings. So if you're using a cloth mask, make sure to have that washed immediately after use with soap and water, and if you're using one of the disposable masks, those need to be discarded. Not because you are at home, it means you can be careless in the handling and wearing of your masks. Caregivers should wear a medical mask that covers the mouth and nose when they are in the same room as the patient. Masks should not be touched or handled during use. You notice I use the word patient. Even though you are at home, you are still a patient because you are infected with the COVID-19 virus. If the mask gets wet or dirty from secretions, replace it immediately with a new, clean, dry mask. Remove the mask using the appropriate technique. Remember how you see us doing it, right? You untie it if it's tied, and rather than touching the front of the mask, you discard it immediately after use, and then you perform your hand hygiene. Not because you are at home, it means you can move around the house as you like. Limit your movement around the house and minimize shared spaces. So don't be going into the kitchen to prepare your own meals, and there are other people who can do that. You cannot run the AC if you have AC with windows closed. Ensure that shared spaces are well ventilated. And not because you're at home, it means you can mingle freely with other household members on the couch watching movies, having a wonderful time. Household members should actually avoid entering the room where the patient is located, and of course maintain the distance of at least 2 meters or 6 feet. So for example, you will need to sleep in a separate bed. Not because you're at home, it means you can allow your spouse or closest relative to be your primary caregiver. Limit the number of caregivers, and ideally, the one person who is in good health and has no underlying chronic medical condition, that person can be your caregiver. So if you have a spouse who is elderly, a spouse with chronic medical conditions, that person is not ideal to be your caregiver. And not because you're at home means you can have visitors. Visitors should not be allowed in the home, not just in your room. Visitors should not be allowed in the home until the person has completely recovered, shows no signs or symptoms of COVID-19, and has been released from isolation, i.e., we who are calling you will let you know when you've been released from isolation. It is normally 20 days for symptomatic COVID persons, 17 days for the asymptomatics. Not because you're at home, it means you can drop your standard on hand washing. Perform hand hygiene as often as possible. It should be performed before and after preparing food, before eating, after using the toilet, and whenever your hands look dirty. If hands are not visibly soiled, an alcohol-based hand rub can be used, but for visibly soiled hands, always use soap and water. And the last point I would like to raise is the issue of cleaning up. So for persons that are at home, we need to remember to clean and disinfect surfaces that are frequently touched in the room where the patient is being cared for, such as bedside tables, bed frames, and other bedroom furniture at least once daily. Now you may think, well, I'm actually quite well, I'm asymptomatic, I can do all these things that Dr. St. Bernard is recommending, but we actually recommend that you rest, you hydrate, you eat, but you rest. Do not take this opportunity because, I am asymptomatic at home, I can be doing deep cleaning, I can be doing all sorts of projects in the yard. You actually need to rest. Clean and disinfect bathroom and toilet surfaces at least once daily. Regular household soap or detergent should be used first for cleaning, and then after rinsing, regular household disinfectant, which would be the one-third cup of bleach to a gallon of water, and that should be applied by wiping surfaces. In terms of waste management, the waste generated by persons who have COVID-19 are considered to be infectious waste, and those should be placed in strong bags or safety boxes and then completely removed from the home. So that today is my update on pitfalls to avoid when self-monitoring at home and how to protect your home with COVID-19. I hand you back over to Ms. Alcantara. Thank you.
Thank you very much, Dr. St. Bernard, for those very important tips. And as we enter into our question and answer segment, I'd like to remind the media representatives, please state your name and the media house that you represent. I believe that everyone is aware that we work within certain time parameters. Please, a maximum of 2 questions, and please get to the point. As always, members of the panel welcome the opportunity to field questions from you. We begin with questions from 98.1, please.
And good morning again to the head table, Stephen Cummings, 98.1 FM. I have 2 questions, and I will try to be as quick as I possibly can. And the 2 questions really addressed to Minister Dayal Singh. Minister, we are back to that place again, a conundrum, I would describe it as, over the applicability of the public health regulations on what is considered to be private property as against public space or property. Now, the police commissioner has been speaking at length, saying under the current provision, he has no power to arrest anyone, who is alleged to be in breach by way of gatherings on private property. Is this something that you may have to go back, maybe talk with the Attorney General to address, or is it something that you can address, during this session? And Minister, again, another question. There is a report that the Scarborough General Hospital has a multi-million-dollar cardiac catheterization laboratory, which has not been used for many years, resulting in patients having to be transferred from Tobago to the Ag Williams Medical Sciences Complex, and putting additional pressure on the system, and in a time when much-needed resources and facilities, and also in the face of COVID-19. The report adds that in addition to the shortage of staffing, there is a shortage of personnel who are appropriately skilled and qualified to operate the catheterization lab machines. Are you able to respond to those two questions?
Sure. Thank you very much, Mr. Cummings. There's something called the letter of the law, and there's something called the spirit of the law. What I would like to discuss, and I'm thanking you for the opportunity, is the spirit of the law. What are we trying to accomplish? We are trying to save lives, save our healthcare system, save the economy. The regulations are there to guide people in how to change their behavior. But in speaking to someone more learned than me over the weekend, and this person put it in context, the spirit of the law sometimes cannot change the mindset of people. And we saw it with that person in the video. Changing the mindset of the person to stop, because this is what people are doing. People are looking for loopholes and technicalities to behave in a certain way. That is not the spirit of the law. As a matter of fact, this is what is giving us problems now, where people do not understand that we are in a global pandemic. The virus is unconcerned about the letter of the law and the spirit of the law. The virus is unconcerned about the discussion between a public place and a private place. As a matter of fact, the virus is now thriving on that discussion, because you have people who are looking at that discussion and are going to the beach and are saying, I don't need to explain this to anyone. The virus is thriving on these discussions. The virus is unconcerned by law, is unconcerned about geography, social status, or any other factor that divides us. Whether it's a political divide, an ethnic divide, a religious divide. The virus thrives on that confusion. We will argue the letter of the law in the courts or wherever. But as a Minister of Health, I am asking people to obey the spirit of the law in all facets of our lives. How we conduct our lives in the public domain and in the private domain. Let us adhere to the spirit of the law and stop looking for technicalities and loopholes to excuse behavior. That is what I would like to say on that one. On the second issue of the cath lab, your question needs to be posed to the Secretary of Health and Wellness and Family Services in Tobago. What I can tell you as Minister of Health, having recognized that in Trinidad and Tobago we are underserved by catheterization processes in the public health system. We only have one in Eric Williams. We went out for tender for one for San Fernando. That was carried in last Sunday's Business Guardian. It is a tragedy of immense proportions that no cath lab is available for San Fernando. We have recognized that, and I personally have championed for a cath lab for San Fernando, because the southern area of Trinidad and Tobago, for lots of reasons, demographic reasons, carries the brunt of NCDs. And this is where you need a cath lab. So I am hoping that a cath lab, under my guidance, will be installed in San Fernando General Hospital in the shortest space of time. We also had plans to go out for tender for a cath lab for COVID, but that was before COVID. That plan for a cath lab for COVID will now be on hold, but we are moving full steam ahead, for the cath lab for San Fernando, where it is desperately needed, because we only have the one in Eric Williams. So I hope that answers both of your questions, Mr. Cummins, and thank you for them.
Thank you very much, Minister. And now we go to AZP News, please.
Hi, good morning. Prior Harry, azpnews.com. I want to take you all back to the beginning of the second phase. Last Monday, Dr. Hines said that the second phase was recognized by patient 139, and he said he didn't know, well, the information is that you don't know how this person contracted the COVID-19. On August 26, the CMO did say that the second phase started by an induced case, meaning that someone crossed the border and were infected. And the Prime Minister on Saturday did say that the upsurge right now is not to be blamed on the Venezuelan migrants. So therefore, there's a lot of conflicting information there. So I just wanted to get that clarified in terms of how did this second phase started. And I'll ask my second question after I get the answer to this. Thank you.
Let me just lend some clarity. Whilst the CMO may have said that there was a link to case 139 to a migrant, it does not necessarily mean prior that the entire second wave was caused by that. And I'll give you an example. We had the Trinidad party planner who knowingly, against all advice, went across Tobago to plan a wedding, which spawned 244 contacts. We have to be very careful how we stigmatize people. So whilst case 139, according to the CMO, may have a migrant component, it does not necessarily mean that the entire second wave was caused by that. I will now hand you over to Dr. Hines.
Thank you for the question. Now, we keep circling back to case 139. I thought that we had actually addressed that the last time we responded to the question, where we did state that there was no documented evidence that linked case 139 directly to anyone with illness. Obviously, the person would have gotten the illness from someone or somewhere, but in the absence of a documented link, we do not have the liberty to ascribe their infection to any particular individual or group. We do recognize that at this point, long after case 139, the spread within the population is linked to individual behaviors of Trinidadians and of anyone else who occupies our land space at this point in time. I am not sure why there is such an interest at this point in time, this far into the second phase, in what happened with case 139, a question that we can't give any additional information on beyond what we've already provided. And I do want to advise that we take more interest in the entire population that is currently experiencing the second wave and that is currently expected to perform or to behave in a particular manner in order to reduce the risk of ongoing spread.
Thank you, Dr. Hines. And I believe that AZP News had a second question.
Yes, just to follow up, there is a number of employees, public servants who are away and they are being paid, but they were told that they may not be paid again because they are trying to come back home and they are not allowed, they haven't been given permission to come back home. I don't know if Ministry of Health...
you are seeing that public servants... Hold on. You made a very serious charge here. You are saying that public servants are not being paid?
No. I'm saying that some public servants who left the country, for work by some for study leave, etc., before the lockdown reborders. and they are still abroad. And there was a circular in one ministry saying that they will be paid until June 2020. And some of them are in a country now wondering whether they can still be paid and they can still meet virtually.
So I will check on that. I have no information about that, but I will certainly check on it. You have raised an important issue.
Thank you.
Thank you very much. And now we go to Guardian Media Limited, please.
Hi, good morning, everyone. Rashad.
Morning, Rashad.
Media. All right, so I have two questions here.
Sure.
First, I'm getting some chatter, and not only me, my colleagues in the newsroom as well, a lot of healthcare professionals have been reaching out to them and saying that there are patients, confirmed COVID-19 patients, being treated in hospitals other than Couva, Cora, and at Arima that you mentioned. We're hearing about Mount Hope and even the Augustus Long Hospital, and they were wondering, and we ourselves are wondering, if that is the case, why is it that those facilities aren't represented on the updates that we receive from the Ministry of Health? And my second question is to Dr. St. Bernard. You made mention of that some patients are downplaying their symptoms so that they don't have to go into the hospitals, and they're basically ducking it, essentially. So I wanted to find out, have we had any instances of patients dying because of such behavior? And if you could hazard a guess as to why, or even from the feedback that you've gotten, as to why it is that these members of the public are avoiding going to the hospitals. Is it that they've heard horror stories? Is it that they've had bad experiences in the past? Why is it?
Okay, so I will try to answer some of your questions, because you see, if this narrative gets out of hand about horror stories and bad experiences. I was at Couva yesterday, and one of the nurses was pointing me to all the good stories about the treatment people are receiving there. And it is this type of narrative, if it takes root in the public's mind, will do exactly what you are saying, Rashad. I was at Couva yesterday. I spent 2 hours with the staff and visiting. 2 hours. And all they can tell me is show me the WhatsApp messages about how good people are being treated. You have heard public personalities in the newspaper saying how good they were treated. So I don't know where this narrative keeps propping up that there are horror stories. And it is that narrative that will give people like Dr. Jeanine St. Bernard trouble in getting people to come there. As far as Augustus Long and Arima are concerned, those are not general hospitals. We have said from the beginning, Arima is used for suspect cases. To answer your other questions about whether people are treated for COVID in other hospitals, when they are admitted until they get their confirmatory test, then they are moved to either Couva or Cora. So there will be that transition period. But it's not to say these patients are being treated for 7 days, 2 weeks in Eric Williams and so on. So I'm really glad that you asked the question. It gives me an opportunity to correct that unfortunate narrative, which will have the effect of telling people not to go to Couva, not to go to Cora. The public officials, and I will not call their names, 2 in particular, have had nothing but praise for the treatment they have received. But you see, the good news does not dominate what people hear on media platforms. What dominates is the one bad thing. But before we go to Dr. St. Bernard to answer your question, because this is important as we give people their pulse oximeters home, Dr. St. Bernard, you really need to expand on what is the happy hypoxic, how that person whose blood oxygen level may be low but is happy, that may not be showing shortness of breath, how they need to manage themselves when they are called. Thank you very much.
Okay, and we move to Dr. St. Bernard, please.
Thank you, Minister. So just to reiterate what has been said before with regard to happy hypoxia I believe Dr. Trotman spoke about this a little bit on the weekend. Happy hypoxia is where you have low levels of oxygen in the blood without the accompanying feeling of shortness of breath. Normally, when persons are hypoxic, which is our medical term for you do not have enough oxygen in the blood, you would be very distressed. You would feel very short of breath. You would be gasping for air, and you would then need some form of intervention. Happy hypoxia, unfortunately, is a phenomenon where the oxygen level is actually not adequate. It is less than ideal. It is less than 94%. Some persons are happy, comfortable, with no shortness of breath, even though their oxygen levels might be as low as 80%. And this phenomenon is one that can confuse not the healthcare providers, but the persons who are experiencing it. So that knowing that this phenomenon exists means that physicians rely on other markers of disease or other markers that will tell us that there is worsening of your condition. So things like increased heart rate, that in itself tells us that something is happening. It may not be hypoxia, but something is happening that warrants an intervention. And that's why when the ambulance visits and they tell us that your heart rate is above a certain number, we would know that's an indication for admission to hospital, even with adequate oxygen saturation levels of over 95%. Some persons will have fever, and that could be a sign that they are hypoxic because they are feeling quite comfortable and they do not have the shortness of breath. Having the pulse oximeter really adds a lot of value to the scenario of our patients being monitored at home, because it means even in the absence of the shortness of breath, when we ask you, what are your readings today? What are the readings for the oxygen levels in the blood? And you tell us 96%, 97%, we say good. And when we ask you what is your pulse or what is your heart rate, and you tell us, less than 115, we know, well, okay, things are going okay. Taking your oxygen mask off when oxygen has been prescribed for you is a dangerous practice and should never enter your mind as an option. So Dr. Trotman alluded to this earlier as well, the issue of persons taking the oxygen mask off. Oxygen is actually something that is prescribed for you by the physicians when you are in hospital. So even though you are feeling fine without your oxygen mask, your blood oxygen levels may not be fine, and therefore we need to emphasize yet one more time, you need to keep the oxygen mask on if you are in hospital and the oxygen has been prescribed for you. Persons wearing oxygen masks are not in an ICU setting. When you're in ICU, you are most likely going to be on a ventilator, in which case, of course, you are sedated. You don't get to control anything. But if you've been prescribed an oxygen mask, we are looking at persons who are independent, free to walk around the wards, and also they do not have a member of staff sitting down just looking at them to make sure they keep their masks on. So I emphasize again, this happy hypoxia phenomenon can make us misunderstand how serious things are with us. Doctors are not crazy people, and so once they have prescribed oxygen, you need to comply by wearing the mask as much as possible, and do not take it off because you think, well, I feel fine and therefore I don't need it. So I hope this addresses the question of happy hypoxia and the need to continue to wear your oxygen mask, and of course, once you've been provided your pulse oximeter, to actually use it and provide us with the readings twice daily when we call you. Back to you, Ms. Alcantara or Minister.
Thank you very much, Dr. St. Bernard. And now I-95.5.
Good morning to everyone at the head table with field to the I-95.5. Just to point out, members of the visually impaired community are complaining that they weren't able to digest the slides in Dr. Hines' presentation. So they'd like to have something done about that, please. My first question for either of the doctors, there's a school of thought that says that the frequent hand washing that we are engaged in now, if it's done over an extended period of time, it can actually lower the body's ability to fight off other viruses that we would normally be exposed to and be able to fight off under normal circumstances. Is there any truth to that? And for Minister Dayal Singh, I've noticed an emerging query where some people are saying that our borders are closed and we are seeing the numbers that we are seeing, yet just to our north in Barbados, in Antigua and St. Vincent, their borders are open and they haven't seen the numbers that we are seeing here. Is there something that they are doing that we are not doing, or would that be a question of comparing apples with oranges if we do such? Thank you.
Well, Whitfield, I have always said from the beginning, every country has to do what they can to manage their thing. It may be apples and oranges. Yes, I don't know what other measures Barbados is doing. I know many countries in the Caribbean do have states of emergency and other measures. So I can't really see what they are doing. I'll let Dr. Hines take the other part.
Okay, and to respond to the first question, thank you. No, there's absolutely no scientific reason why washing your hands frequently would reduce your body's ability to respond to any other pathogen. In fact, quite the converse. When you wash your hands more frequently, you remove not just COVID-19, but all the other pathogens that can be transmitted via contaminated hands to your body for your immune system to fight with. So washing hands doesn't only protect you against COVID-19, but against all of the diarrheal disease that we're seeing slightly less of, and against other respiratory pathogens beside COVID-19. It does not in any way weaken the immune response. Back to Ms. Alcantara.
Thank you, Dr. Hines. And now TV6, we're ready to field questions from you.
Hi, morning everyone.
Morning.
From TV6. Dr. Hines, you said on Saturday and also you repeated today that as far as daily positives are concerned, things are starting to look favorable, although it is increasing, is not increasing as much. Now, shouldn't we be concerned though, Dr. Hines, that those increasing number of positives are coming from a significantly less tests reported being submitted, significantly less tests? For instance, this week gone, there were 700 positives, and it would have come out of probably 2,000 based on last week, 2,000 samples submitted. And even if it was based on the week before, there were 1,511 samples submitted. My second question, you did speak about the pneumonia-related mortalities. Now, I'm going to ask you if maybe next week, if you can share with us the excess deaths. And the reason for that is because research has shown in other countries, at least the US, that there are other deaths that are indirectly related to COVID, other causes, healthcare shortages, overburden of healthcare system, and then people are dying from other deaths, such as serious conditions, such as stroke, diabetes, heart disease. Thank you, Dr. Hines.
Okay, so to take the first question, actually, the fact that the number of positives we're seeing is coming from the number of tests that we're doing indicates that we're testing the right people. What we do is we employ a testing strategy that gives us the highest probability of finding the relevant infected individuals. What you would have seen is a few cases where we would test through a contact web of exposed individuals as a result of the epidemiologic situation where one or two cases would have arisen from. So that is the strategy that we employ. We test around positive cases in such a way that we can identify other positives, possibly not symptomatic, who may not have otherwise come to the attention of the health system. So the increase in our pickup rate is actually a success of the testing strategy. And to address the second point that you made, I just did show the excess mortality and the fact that we don't currently have any. Excess mortality for pneumonia is shown by what I just demonstrated, and the same applies, and we can show the graph, yes, at the next conference, for all-cause mortality. But all-cause mortality has basically followed the same pattern. At present, we do not see mortality either from all causes or from pneumonia specifically that exceeds the current expectation. But we can also put the all-cause mortality graph into the public domain to help with the comparison. So thank you for asking.
I just want to go back to Whitfield's question about comparing apples with oranges. So I'm just doing a quick internet search from reputable websites, Whitfield. I'm just repeating it because I am always careful how I speak about CARICOM countries and other countries. So I'm just repeating what I'm seeing on reputable websites. Grenada, declared a 21-day state of emergency in March. On 17th April, Parliament approved it to be extended for 6 months. Barbados, just repeating what a reputable news agency has said, had a state of emergency until the end of August. So that's why I said we have to be very careful how we compare Trinidad with any other country. Different countries employ different measures. We have not gone the way of a state of emergency. So yes, it seems to be comparing apples with oranges when you compare Trinidad with Barbados or any other country. I hope that lends some further clarity to the question.
Thank you, Minister and Dr. Hines. And Express News, we are ready for you now. Express newspaper.
Good morning, Kim Bojang from the Express. Minister, there's an issue where the family of a person who has unfortunately passed from COVID-19 is attempting to get their medical records. We would like to ask, what is the process if the relatives of a deceased decide to challenge what they are being told about the person's death, access those records, seek an autopsy? There may be more of this happening. How does the ministry treat with that? Is there a process to go by?
Yeah.
Also, the homeless persons, I know some more clarity was issued where we were told that there were in fact no tickets issued to homeless persons for not wearing masks. But Port of Spain has a really large ongoing population, not just of homeless people, but people who are just disenfranchised and they tend to spend a lot of time out in public. How are we going to treat with people who live on the streets? How will they? I think the question has been posed, but if we could also, again, get more clarity. And we see the issue of public spaces, public versus private spaces, is definitely on the table to be clarified. So how would these people be expected to cope with the law regarding the wearing of masks?
Okay,
Thanks.
Thank you for your 3 questions. So I just put in your leg, Kim. Yeah. Okay, so let's deal with issue number 1, medical records. It has always been the policy to make medical records available to any family next of kin once they have requested it. This is an administrative function that goes on unimpeded. If someone wants to write a lawyer's letter, that is fine. But no RHA and the ministry has absolutely no policy to make it difficult for the next of kin to access medical records. So let me say that up front. Whether you are prince, pauper, whatever, the policy has always been to make medical records available once they are requested by the designated next of kin. And that is what we have problems with sometimes. Because sometimes pumpkin vine family or a friend comes for the records, and then we have to determine, is this the person on the admission form who is the next of kin? So that is one. The issue of masks for the socially displaced, that question was asked, and I was told by the Ministry of Social Development that they have in fact provided masks for the socially displaced. The issue of private and public space, I think I went into some detail about the spirit of the law versus the letter of the law. We are simply asking people, whether you are home or whether you are outside, that this virus does not discriminate whether you live in any particular area. It doesn't discriminate as to your political persuasion, religious persuasion. I went into a long explanation that the spirit of the law is trying to get people to change their behavior. So whilst we look for loopholes, the virus enjoys that. Whilst we fight over these things, the virus does not care about the Constitution. The virus does not care whether I attack you on a beach, on Frederick Street, in Scarborough, in Carnby, in Point Fortin. We are just asking all persons to adhere to the public health guidelines to save your life.
Thank you very much, Minister. And we go now to Tobago. Tobago Channel 5, please pose your questions.
Hi, good morning. Candice Jackson from Tobago Channel 5. My questions are, could we get an idea of what the ratio is of nurses to patients in ICU throughout the country, in Trinidad as well as in Tobago, in the various hospitals? And also, how is the quarantine order been working? Has there been success in ensuring that patients stay at home when they're supposed to and that sort of thing?
So thank you. I will take your first question. I don't have the actual ratio now, but let me just say, even before COVID, there was an absolute shortage of ICU nurses globally. And that is why we went to Cuba to source ICU nurses. And every time we go to Cuba to source specialties in nursing and medicine that are not available here, we have to put up with this narrative that we are taking the jobs of locals. We always see, in an effort to fill the shortages of specialities in nursing and medicine, we go to Cuba. We went to Cuba and I think we got 11 ICU nurses. We have trained up over 150 ICU nurses locally. And there is a global shortage of ICU nurses even before COVID. I just want to put that on the table. This is not an ideal situation. But COVID has made an already tenuous situation worse as far as ICU nurses globally is concerned. And I will let one of the other doctors, maybe Dr. St. Bernard, to talk about the quarantine issues at home.
Yes, we move to Dr. St. Bernard, please.
Hello, and thank you for that question regarding quarantine orders. That is actually a very relevant question that you've asked. Quarantine orders have been issued in more than one manner. When patients are swabbed, at the point of swabbing, they would be issued quarantine orders. So that is, the person has come to the facility, they've done a drive-by, or they've had the swabbing done at home, and the quarantine order is issued at that point. They sign it. We would have a copy, or they would take an image and send to us, and we would then have that on file. With regard to getting the quarantine orders to the contacts of the COVID positive persons, different counties would institute or use different methods to get the quarantine orders out. So we have been using, like in County Carney, we use the police, and we would have the police, we would deliver the quarantine orders to them. They would then drive to the homes and deliver them to the persons for them to have them signed. In terms of your question, how has it been working? I'm not sure if you're asking in terms of if persons have broken quarantine, if, the police were able to then, connect with the quarantine orders. I'm not sure exactly what you're asking, but we have a system for getting the quarantine orders to the persons, for getting it signed, and for having it. But I don't know, I can't answer the question with regard to having to enact the law or to activate if a person has broken quarantine, what the police officers are doing. I would not be able to speak to that issue.
And let me just fill out the question on ICU nurses. 2 weeks ago, we again have reached out to Cuba for more ICU nurses because we simply don't have enough. And I'm hoping when we do that, the narrative does not turn that we are taking the jobs of locals. We are not. Every time for the past 15 years, we bring in these specialties which are not available in Trinidad in the numbers that we want. We have to reach out to places like Cuba. So we have in fact already gone out to Cuba for more ICU nurses. And I'm hoping again, but it is going to happen. The narrative is going to come out that we are taking the jobs of locals. We are not. Okay? Thank you very much, Candice.
Thank you, everyone that participated today. We've come to the end of this morning's media conference. Everyone, please be safe and remember to wear your mask.